It is my great pleasure and honor to introduce the moderator for our next session, Lisa Baxter. Lisa is the Director of Major Gifts at MLK Community Health Foundation, and she's responsible for the strategic direction of managing the key donors and fundraising initiatives that are essential to developing, expanding, and stewarding major philanthropic support for the hospital here in South Los Angeles. She has worked in the nonprofit sector for the past 14 years and currently serves as the board of directors on the board of directors for the Association of Fundraising Professionals for the Greater Los Angeles area, and also is the 2021 Vice President of the Inclusion, Diversity, Equity, and Access Committee for that association, the acronym of IDEA. An amazing friend, an amazing partner of ScaleHealth, an amazing innovator here in the Los Angeles area. So with that, I will kick it over to Lisa to take it away and introduce the rest of the speakers. Lisa, over to you.
Thank you, Taylor. I am so happy to be here. So we are here to talk about silver linings, and that is defined as a sign of hope in an unfortunate or gloomy situation, a bright prospect. And I would imagine that would be a welcome topic considering the events of the past year. How we have evolved, how have we collaborated, and how have we thrived during this time has really been, I think, the questions on everybody's mind. And how has our creativity taken shape and helped to carve out a path for the future before us? I know a little bit about hope because at MLK Community Healthcare, we were able to build success very early on during the pandemic because we found what I call opportunity in the chaos. As a fundraiser, I quickly shifted gears, adapted, and remained nimble as my role pivoted to overseeing the intake of in-kind donations. And what resulted was the launch of our first in-kind donation program, with donations totaling over $300,000 in value, over 50,000 meals donated to our front lines, opportunities to support local businesses, a pipeline of in-kind donors to convert to cash donors, over 19,000 products distributed to staff, and as a foundation, over $2 million in cash raised from donors near and far. Preparedness, infrastructure, and innovation is what really moved us forward. Well, that and leveraging the heck out of the media attention that we received, because that is something that we weren't normally used to. So it really helped to shine a light on our work. So today, we are joined by three dynamic leaders who have extensive and successful careers in the healthcare space and who know a ton about silver linings, collaboration, and how the power of the people have lent to their collective success, because I think that's one of the most important things, how people came together during this time. Christina Campos is the administrator of Guadalupe County Hospital. It is a 10-bed hospital in rural Santa Rosa, New Mexico. And she has served on numerous national rural health care committees, including the AHA, Ensuring Access to Rural Healthcare Task Force, as well as the Future of Rural Healthcare Task Force. And she is a former AAHA Board of Trustee and a former member of the HHS National Advisory Committee for Rural Health and Human Services. She currently serves as the chairman of the New Mexico COVID Economic Relief Council, as the chairman of our local Economic Development Corporation, and on several other boards and committees. Our next panelist is Peter J. Wright. He is a vice president of operations for Central Maine Medical Center and the president of Bridgeton and Rumford Hospitals and Central Maine Hospital's long-term care division. He joined CMH in March 2019 after serving 6 years at Dartmouth Hitchcock Health as president and CEO at Valley Regional Healthcare in Claremont, NH. His entire 18-year career has been spent in Northern England, New England. He currently serves as the board of trustees of the American Hospital Association and as the chair of AAH's Regional Policy Board for New England. Mr. Wright is a board certified in healthcare management and a fellow of the American College of Healthcare Executives. He has been a member of the Rotary International since 2003 and a former trustee of the Vermont State Colleges. Tracy Donegan is the Chief Information and Innovation Officer at MLK Community Healthcare. Go, Tracy. Tracy Donegan brings more than 20 years of diverse experience in the healthcare industry to her position. And prior to joining MLKCH, Tracy was an Assistant Vice President of the Cognizant Health Care Provider Consulting Practice. Tracy dedicates her volunteer efforts on mentoring graduate students and early careerists. She's an active member of Cornell University's Alumni Admissions Ambassador Network, the American College of Healthcare Executives, and currently serves on their Executive Outreach Committee, as well as the Healthcare Financial Management Association, and serves on the advisory board for ScaleHealth. Thank you all for joining. So let's get started. Now, Christina, I know that you know a lot about evolution because you started out at your hospital as a hospital volunteer. So how has your hospital evolved during COVID?
Not to jump in, but I think we're still waiting on Christina.
Okay.
So we have Peter and Tracy here.
Well,
We'll come back to Christina.
Okay, Christine, yes. So Tracy, how has a hospital evolved during COVID?
Well, I have to say, we've always been a sort of confident and feisty hospital. And I think the pandemic really validated that in times of high stress and high demand, we just don't change. I mean, we are who we are. But I have to say, we did evolve in our validation of empathy towards our staff and those involved in direct care. And we really sort of renewed our focus and support of them more than we've done before. And I think that's the biggest learning and evolution that we have made as an organization.
Thank you, Tracy. And I think that Peter knows a lot about renewed focus. He came into his new role when it was really challenging. And then the next year, COVID hit. So Peter, can you tell us a little bit about how your hospital has evolved during this time?
Sure. So I work within a 3-hospital system and do some work at each facility. And they're in 3 very distinct counties in central and western Maine. We're small and rural, and I always put that in context because it means different things to different people. Every time I say I'm small and rural, I listen to Christina talk about where she is, and then I think, we're kind of like the city. But, in Maine, like many communities across the United States, it wasn't our response as a hospital, it was really a community response. So we certainly changed very rapidly inside of our buildings. Each of my hospitals had a very unique challenge to overcome. And one community is relatively poor, it has a paper mill, but kind of a broken industry. And another community is quite affluent, a lot of second homeowners. And so, each challenge was different, but whether it came to launching technology, whether it came to bringing our teams, our small groups together to rally, it was embraced by the community that we were serving. And, we're operating inside of towns that are 5,000 people. So we did it kind of as a hospital community, but also with our municipal and EMS partners, because it really was a full-fledged community response.
Mm-hmm. Thank you for sharing that. And, as I said earlier, I think that I would like to think that in all communities, they came together in a way that was really special and unique, and probably in unprecedented ways, because I know in South LA, we had never seen that type of support before. And so not only was it needed, it was definitely wanted. And we felt like, this was a support that we know we've always deserved, but I think it just took a little bit longer for folks to get the memo, but we were really surprised.
Yeah, Lisa, that's a good point. So when I came into one of the communities, it was during a very divisive time, as you had kind of alluded to earlier. We were at odds with the community. The community was actually asking our corporate office to divest of the hospital and give it to our competition, which was a very interesting ask. The answer was no. And so we went from that, I feel like my first day, there were torches and pitchforks at the front door, to really a dramatic 180, where we not only There were people putting signs on our front lawns, calling us heroes, which I don't think anybody in our building thinks that we are. But deliveries of food and things like that to support the team working around the clock. But also we became the single source of truth. So our relationships with our municipal partners, town managers, select boards, EMS chiefs, we were their single source of truthful information. They had no network to get information about how they should respond, whether that was advising businesses within the Chamber of Commerce, whether that is how municipal operations should or should not continue to move forward, supporting EMS, working with fire and police. They just had no source of information. So we held weekly calls to brief about where we were in our response, where we were with our supply chain, and then be a source of information of, should they do this? Should they do that? Is this true? Is that true? What do they know about this executive order from the governor? I think small towns have few resources. And so, being a resource for them to just get an answer or some truth was a really uniting factor in each of our communities.
Yes, you made a good point about being a resource. And speaking of that, Tracy, how has your hospital changed the way you incorporated technology or innovation as a result of COVID?
Well, we've always been sort of early adopters of technology, and we're very accustomed to using creative problem-solving techniques to solve just big constraints that we have. So, I mean, that really didn't change, but what changed for us is how we implement the technology. We went with the approach, like, for example, telemedicine, we just had to get it in and it just had to work. And usually in those types of implementations, you spend a lot of time on change management, making sure physicians, are buy into it and community members can use it. And this time we just had to get it in and then, grow it and optimize it over time. So that was a big thing we did. The other two sort of innovative approaches that we had was in the way we planned, which really helped us out a lot. We planned for the worst and then worked backwards. So we're constantly ahead of the game, having our eye on the volume of COVID patients and quickly switching gears to that next level of urgency. And then the last thing is really utilizing our vendors and leveraging them. I mean, vendors, as you know, many of you want to help your clients in all times of good strength and need. And this is where our vendors really came in and really helped us. So those are the key takeaways in terms of how we incorporate technology and innovation.
Yeah, and I think that the word leveraging here has been, the word of the day, because even in our fundraising, we really leveraged the relationships that we had and in order also to build new ones. And one of the things that I wanted to go back to is you spoke about creativity. And I think the creativity that went into our innovation was really through our approaches. And I know for our audience out there that, are entrepreneurs and startups, I think sometimes they may not understand that innovation doesn't have to always mean something new, but it just could be in the way that you approach it. Can you talk a little bit about that?
Me?
Yeah.
Yes, I mean, I have to use our emergency room as a perfect example. We have a capacity of 40,000 encounters a year, and we had been experiencing about 110,000 over the years, and we have a hard constraint on space. So there was a lot of innovation on the way we organize the space, the process, the check-ins. For example, the physician goes out to the patient instead of coming in, all these unique ways to make use of the space that we had. And in the chance of COVID, we literally took advantage of every nook and cranny in the hospital to increase our capacity. And so that's where I'm thinking innovation and creativity and just using what works.
Right. And at the head of that, obviously, with the people. And Peter, you know a lot about that because I know that you invest in a lot in your team and in people and in really bringing out the best in them. So what accomplishments by you and or your team are you most proud of during this fight during COVID?
Yeah, just to Tracy's point, Rahm Emanuel said it. It was really a Winston Churchill quote of "Never let a good crisis go to waste." And I think we've all uttered that phrase over the last 18 months. I think in times of crisis like this, we really find out what we're made of. It's easy to make change or to espouse to a certain set of values when everything's smooth and you have plenty of time. And this exercise is repeated every day in our emergency rooms and when we have a code or sometimes in the OR when it gets tough. But in this crisis, we really found out who we are. And what I'm the most proud of is I had always known that my teams in Bridgeton and Rumford and even here at the medical center, they were strong groups. But I never knew how strong. And so when times were really dark and either volume was low or we had really sick patients and people were still worried about, am I going to get COVID by taking care of a COVID patient? Mm-hmm. I saw everybody come together. I saw titles go away. I saw people who would previously take stands about information technology go away. And so it wasn't, are we going to do this? It's, how are we going to do this? And so a lot of what we did was to support Tracy's point, technology, we've got to go to telemedicine visits. Let's just do it. We found a product, we pulled the trigger, and we spent time fixing the plane while we were flying it, which under any other circumstance probably would have drawn a lot of criticism. But rather than say, oh my God, this isn't working right, the approach of the team members was, okay, we got it up and running. It's clunky. Here's what we need to fix today. And people dropped everything else and everybody really focused on the patient. And so all of that happened because of putting time and energy into relationships. As you kind of alluded, I put a lot of stock. We're an organization of people taking care of people. And so my leadership style is to invest in the people. I have a trademark phrase. I'm a pretty simple person. And I tell my teams, our strategy is three things: us, them, money. You take good care of your team. They take good care of your patient. Patients who are well cared for will come back. They'll be loyal. You retain that market share, and that creates financial viability. So leading up to all of this, when times were good and we weren't in a pandemic, we were spending a lot of time building relationships. So when our backs were up against the wall, when we were up in the middle of the night trying to figure out how we were going to keep our team safe, no one was wondering about our core beliefs. Did we really want to support the people, or were we just going through the motions? They knew we cared about them. They remembered us, them, money. And so they believed, and then they could focus on what they needed to do rather than checking and making sure that we were actually doing what we said we were doing. So those relationships really came to bear when the stress was highest because we had invested so much in them prior to me up. So I'm really proud of the team, of the people of dropping titles, of really coming together and just doing the right thing. And I'm proud of the fact that we saw certain people rise to leadership roles. Sometimes it was people who we knew had the potential and just weren't living up to that potential, who found their space. And sometimes it was people we hadn't even suspected were leaders, and they just emerged. And so we embraced that and really provided opportunity for them to continue to grow.
All very good points. And I hope the audience is notating the emphasis on building relationships. And this was not just something, of course, that happened when COVID started. This has been, something that has been ongoing and that has to develop over time. Same in fundraising, just same in just business in general. And I just want to just bring attention to the power of people and collaboration. And I know that, Peter has one of his quotes. I know you like a lot of quotes. You said service over self. And Tracy, I know we know a lot about service over self at MLK. So can you give me some stories about collaboration as well?
Yes, I just want to comment on some of the things that Peter said regarding relationships. It's just so important, especially as we grow our early careerists and children in the world. I mean, these are the qualities that take us through, times of great need, and we need to support and teach and nourish how we build relationships, give time to it. But in terms of the time of the accomplishments that my team had, I mean, in service over self, that was, I guess, Peter's line. I just have to say our informaticists stepped away from their job and they went into direct patient care. And that's a great example of service over self and the amount of commitment that they had to our community, giving up their day job and not having practiced for several years and just getting right into it. That is something I'm very proud of. But in terms of my team itself, though, I mean, just in the beginning of the COVID, the demands were insatiable and the turnaround times were just completely unreasonable in normal times. But, we know in COVID, unreasonable turnaround was really what you needed to do. And we did accomplish it. As Peter said, we witnessed people you didn't even know were leaders take on sort of a leadership road. And it was just such a great thing to say. And we've done so many things so quickly, transitioning the workforce to a remote environment, whereas before, when you worked remote, it wasn't that accepted. So changing that culture overnight and providing the tools was a big deal. Keeping our patients and our employees safe at home, these are the things that we're proud of. We also did other things minor around education, transitioning more towards web-based education, quickly creating those pieces so that new nurses and new staff could safely get trained at home. Just so many things, a bilingual chatbot online. I'm just proud of how we just naturally came together as a team. It just felt so natural and organic. And I'm proud that we had that foundation to be able to do that.
Yeah, I concur because, and probably Peter feels the same way, that you were even working with people you normally didn't work with on a daily basis. And so now even new relationships were being forged. Peter, can you tell us a little bit more about any stories, key stories of collaboration and innovation at your hospital that particularly comes to mind over the past 18 months to stand out to you?
Oh gosh, yeah. I mean, it spans everything. So one of the very interesting issues we had to tackle was clothing. So our providers, we're an organization where frontline providers are required to bring their own scrubs. And there was probably about 2 weeks in, we were challenged with the issue of someone came and said, I don't want to bring these COVID clothes to my house. And so we had to figure out, for an organization that didn't provide scrubs, to not only how can we provide them, but how do we safely handle them? How do we launder them? How do we keep track? So a bunch of people came together. I don't even remember who was on the task force. And we have a scrubs vending machine. And you use your proximity chip and your ID badge to check out scrubs. And then we had another machine where you return them and you check them back in. And I'm sure at larger hospitals, this is kind of an everyday thing, but it was the most bizarre concept. I remember giggling and saying, do you get a Reese's peanut butter cup when you go get your scrubs, or which is the best candy ever. So it was just repeated. Now, what's interesting is that crossed over a lot of boundaries. You have people mostly in the emergency department or on our nursing units working with supply chain that they don't normally interact. So they don't have those relationships we talked about. And so, every clinician looks at supply chain and said, your job is just to, get it on the cheap, right? How do you reduce our cost? And so what we had to do was to help them understand both sides. Remember, all these people, how many people here think that these folks in the room showed up with the idea of, I wonder how many people I can screw up today. I wonder if I can ruin people's day. I wonder if I can get them a virus, right? Of course not. When you say it out loud, it becomes ridiculous, right? And so you say that out loud and you go, well, no, of course they're here for the same reason that I'm here. They're here to make sure we take awesome care of our patients and we keep each other safe. We're on the same team. It seems obvious, but you had to say it out loud. They had to say, yes, I actually believe that supply chain is here to get us the things that we need, right? The supply chain people say, I take great pride in getting you everything that you need when you need it, not too much, and to make sure it's a quality product. Yes, I try to get the best price, but I have no interest in getting you junk, because if it's junk, then you think I'm not taking care of you. It's like people in IT, right? They don't show up and say, wonder how many computers we can shut down today, right? They take pride in knowing, yeah, guess what? You came to work today and your computer worked great. You didn't even think about us. That means we did our job, because 75 different things happened that could have shut it down, right? So everybody has that pride of doing a good job. And so bringing those folks together in these kind of non-traditional circumstances to solve problems. It was interesting. The first thing we had to do was agree everybody's here and is rowing in the right direction.
Amen. And I concur on your candy choice. And I love how you said, really thinking about non-traditional ways to create solutions. And I think that that's definitely how everybody has been moving forward. And sometimes the most simplest solutions bring about the biggest impact. And we know a lot about that at MLKCH. Tracy, can you tell us some stories of collaboration that stand out for you?
Well, first of all, that's the best candy in my opinion, but I recently moved on to peanut butter M&Ms, and I get mad at my mom every time she buys them. But in any event, I mean, from a global perspective, I just can't beat the vending machine concept, but just from a practical standpoint, I was really impressed with the leadership team here. Hospitals are used to forming what we call a hospital incident command center, and we formed one right away. And it was from that core that we were to be able to manage effectively during this whole thing, because we had that one foundation and core of the whole event that we can turn to. I mean, we incorporated daily huddles and consistent communication, daily PPE updates, safety stories, and recognition. We also, from an IT perspective, resource use in IT in these days, in this kind of crisis, was important. So we set up our own IT command center that reported into the hospital incident command center, so that we let them prioritize what we work on. Because you can only imagine phone calls coming in, people needing things right away, but in the grand scheme of things, did they really need it right away? Was there other important things that we can do? And then I also mentioned our innovative use of our partners, and then the way we planned for the worst and creating thresholds as we moved into different phases of our of the pandemic.
Mm-hmm. You and Peter, I know that you are very optimistic, and I want to know, what silver linings do you see coming out of the pandemic?
Yeah, so we've seen some great changes, and I'm hopeful. Our emergency department volume across the system dropped 25–30%, and with few exceptions, it has stayed there. We've seen greater utilization of primary care. We've seen an uptick in urgent care and walk-in clinics, and that's perhaps the most exciting of all the volumes that dropped. They've pretty much come back 95% or more. And ED volume is something that I'm really excited about. In small rural areas, emergency departments are not really emergency departments. They are primary care safety nets. If you can't get an appointment, you just go to the emergency department. Because more often than not, unlike our urban partners, we don't have 5, 9, 12-hour waits. You know, my in and out time is 120 minutes. From the time they show up to the time they're discharged and walking out the door. We have a door to dock time in most of our hospitals of inside of 20 minutes. So it's just a difference. It's not better or worse, but to see that, you know, inappropriate utilization go down was really, really encouraging, I would say. We initially saw a huge uptick in the use of technology and telemed technology, which we thought was, you know, finally we got the providers to agree to it and the staff, we got the patients to agree to it. All of that isolation, as we know, created the behavioral health aspect of, you know, what I would call the hidden pandemic. And so the moment the safety precautions came down and emergency orders, we saw everybody flood back to the office. We can't get them to use the technology. They're so desperate to see people. We had a meeting earlier this morning, and one of my colleagues said it was so exciting to shake somebody's hand from a meeting earlier today. So I'd wish that one had taken up, and I think it perhaps will as we get back into flu season. You know, the other really encouraging and exciting thing is we did not have one case of the flu the entire winter. Now we're in Maine. It's not only cold, it's not only so snowy, but it's very damp. It is a ripe, you know, manifestation of flu. We always get it really hard. And we had 0 cases, which says to me, the flu is completely avoidable. If we just wear a mask and wash our hands, we can never get the flu again. So that was really encouraging. So much so that our governor has now mandated the flu shot for healthcare workers. That will be met with significant pushback, but it is what it is. And it'll be interesting to see how that stems the tide of that particular infectious issue moving forward.
It seems like all of the silver linings that you had at your hospital is really setting the foundation for how you move forward in the future. And that is the same at MLKCH. Tracy, can you talk a little bit about our silver linings?
Yeah, I mean, we had many of the silver linings that Peter spoke of. One of the ones that really isn't talked about a lot is, you know, the staff, the non-clinical staff, being able to sort of reclaim their lives in a way by working at home and keeping them there permanently. There's so much flexibility when you're working at home. You don't have to worry about making your lunch or commuting and that extra stress. So it's nice to see the staff really happy. The other silver lining, of course, was for our direct staff. We were able to hire a wellness coordinator or specialist and coach who is now permanently part of our staff and dedicated to providing programs to help the wellness of all of our staff, but also to treat any kind of stress or impact from a behavioral health standpoint on our patient facing staff. So, and then a couple of other things we mentioned before, the unexpected leaders emerging. So now you have a new fresh eye on them and you're able to bring out that leader and keep them moving along their career, whereas before you might not have noticed. And the confidence that we have and confirm that we have to achieve great things with a great foundation, a human foundation. And then selfishly, we had just finished our digital strategy, and we were able to start that, and we hadn't planned that for another year. So
Mhm.
that was a good thing as well.
Yes, and I know you were super excited about that.
Yes.
And Peter mentioned, behavioral health was the hidden pandemic, and I would agree. And I think right now we're kind of waiting with bated breath to really find out what effects, have really truly, how much this time has affected all of us, especially, our frontliners included. So how are you all addressing mental health at your hospital or within your teams? Peter?
Thanks. We saw some really scary things. We saw a huge skyrocket of substance abuse, domestic violence. We lost, in our small community, we lost 6 people who took their life in the single month of December, which is 3 times what we would normally see, even at its worst. It was really bad. We leverage technology in our partnerships, so we don't have a department of psychiatry in our system. We have a partnership with Mass General Brigham, and we're able to launch a telepsychiatry to be able to handle crisis patients in our emergency departments and on our inpatient units. We've created a really strong partnership with a private practice group that does substance use recovery. They also launched a recovery center, and so we integrated them with our own clinician who does substance abuse, and we've really been able to launch that. The reduction in restrictions to get X waiver for primary care physician or primary care providers was really helpful. We're trying to leverage that. So phase 1 is to have 1 practitioner in every one of our primary care clinics with the eventual goal of having 2 or more. But all of that said, my emergency departments are regularly flooded with suicide ideation and behavioral health patients. In Rumford, we have 6 beds in our emergency department. I came into the hospital one morning and we had 5 patients. We literally shut down the emergency department with behavioral health patients. I have staff who are leaving in droves because they are getting beaten. And there is just repeated and nonstop violence in the ED on the inpatient units that's connected to this behavioral health crisis. So it has so many levers. There aren't enough beds. Several years ago when I was in New Hampshire, we were in an advocacy forum saying you can't build enough psychiatric beds. What we have to do is start building the infrastructure upstream. We need to increase the capacity on the outpatient basis. And then we need to look at the full spectrum and increase the capacity of safe housing. So if you think about behavioral health, if you think about proactive, just the way we did 20 years ago with primary care, let's invest in primary care and stop the disease upstream. We're now taking that same approach with behavioral health. But you also need to look at each step. We need to invest and train more in our psychiatric facilities, but we also need to provide training in our acute care facilities. Our emergency department staff would often say, well, those aren't our patients, those are the psychiatric facility patients. And the answer to that is no, they are our patients. They're in our community. They need our help. They're in emergency. We need to learn how to take care of them. And that starts with merely learning how to speak to them.
Right, exactly. And I think those steps are so important. And the fact that hospitals are really focusing on that, that is really going to set us up for the future. Christina Campos has joined us. Christina, I also want to ask you, how have you all addressed mental health during this time?
We had started out well before COVID by developing a mental health task force for the community, and it was made up of members from the schools, from the correctional facility, from businesses and law enforcement, as well as healthcare providers. So a lot of it was, kind of tightening that up and making sure that we had warm handoffs from our ER, upon discharge to local mental health providers so that people would quit falling through the cracks. because often we found that we could stabilize them or we could transfer them out if at all possible to a higher level of care for psychiatric services. But we need to make sure that they had that safety net within the community where people could continue seeing counselors on a long-term basis. And a lot of it also was removing the stigma around getting treatment for stress and anxiety, and having a lot of conversations with our staff about it, making sure that our staff as well were able to access services within the community. But we do see a huge need for providers. We see a huge need for beds across the state for patients that have both health issues and psychiatric issues. There's some behavioral health hospitals that won't take patients that have health issues, even diabetes, or if they're on withdrawal. So that makes it really difficult to get them out to the proper level of care. And then the other issue is transportation, how to get those patients from our facilities to those behavioral health or psychiatric hospitals has proven to be a huge challenge. It was a problem before COVID. It was exacerbated to a certain point. And I think what we're seeing right now, Peter talked about how we weren't seeing a lot of soft cases in the ER during COVID because people frankly were afraid to come and get COVID in our ERs, even though they were probably safer than the supermarket. Right. But now that those things are settling down and the crisis to a certain extent feels like it's over, all of these other issues, healthcare issues and behavioral issues are bubbling up. I think we're seeing more stress even with staff that don't work on the front lines, but have been coming to work every day, either in health information or IT or even administration. You can see the stress is bubbling up now.
Mm-hmm. Yeah, you brought up a good point about, that these things were happening before COVID. COVID just really shone a light on all of the different needs and inequities. And speaking of that, we all know that ScaleHealth is committed to improving the health and wellness of the global community and has been shining a light on the systematic issues within the healthcare system. How have you and your hospital use innovative thinking to fight inequality? Tracy, do you want to start with that? Tracy?
Yes, can you hear
Tracy?
me now?
Yes, now we can hear you.
Okay. I'll have to speak to IT about the fact that I just lost my connection. Okay. What was the question?
So I said that ScaleHealth is committed to improving the health and wellness of the global community and really shining a light on the systematic issues within the healthcare system. How has MLK used innovative thinking to fight inequality?
Well, that's a good question. We're trying to fight it every day. One of the big things it seems like it's a big source for a lot of things is the structural disparities in the way that we are reimbursed. And it just seems to downstream impact. I mean, we have Medicaid, but predominantly Medicaid population, they have the lowest reimbursement. And that just causes problems throughout in terms of attracting physicians to the community, being able to invest in, programs and other things that would help Medicaid patients that they don't typically reimburse for. That whole thing needs to be looked at. And I think that's where we're really trying to focus our attention on is policy, because that we feel is going to have a lasting impact for a lot more communities and hospitals, not just ours. So I think that's the biggest thing that we're doing.
Yeah. And Peter, I know that you've done a lot in payment reform. What are some innovative ways that your hospital or approaches your hospital's taking?
So we have the unique privilege of being the lowest cost hospital in the state of Maine, which is great towards the mission of providing low cost care. We're probably 30 or 40% cheaper than our competition. Not so great when you're trying to make a bottom line. I'd have to say this is an area where we had a big miss. I think Central Maine healthcare, I think the state of Maine, I think our field really missed the opportunity. If you go back and look at the last 18 months, we've all been suffering economically, right? I mean, the universal headline towards hospitals is stepped up when everybody needed us, and now we're all feeling it across that time frame. Wouldn't it have been great to, if we could have created a model where our payments were fixed every month, our revenue was fixed every month, and we were just trying to control our costs? Very much like capitation, global payment, and we missed that opportunity to make the jump. And I just, of course, hindsight's always 2020. I just wish we could have looked and said, oh, wait, all our volume's going to go away, and at least for 6 months, why don't we fix the volume, right? I mean, I can tell you that all the insurance carriers, they didn't give any refunds. Their premiums were coming in and watching their expenses drop. Medicare, same thing. So the money was there. And instead of converting it into stimulus payments that sometimes were grants or sometimes were loans, we could have looked at it as a per member per month, capitated fee and figured out how to live there. I think, it's easy to say that. Obviously, the hard part of that is attribution, who gets credit for the patient, and there would have been a lot of logistics to work out. But gosh, there was a lot of opportunity that we missed, and I don't know, I mean, hopefully, knock on wood, we don't have another opportunity like that where the volume drops out. So,
well, it sounds like there's a lot of lessons that have also come out of this, silver linings and lessons. And Christina, can you tell us what is the most important lesson that you've learned during this time?
I think the big lesson was we are capable of so much more than we anticipated. We were able to go immediately from, just everyday management and operations of the hospital to a testing center. Well before the state could put up their public health offices in rural areas, we were up and running with testing. And then we were able to pivot immediately from there to a treatment center and, quickly adopt the best practices that were being put forward by CDC and Johns Hopkins and other organizations. And even in the midst of that, we were able to start a very strong vaccination campaign with our community. So one of the lessons is that we are, especially the rural areas, that was one thing that was pretty amazing, is that we were very, very capable of being anything that our community needed us to be, and be able to build trust within our community. We're like Peter, we're one of the lowest cost, probably the lowest cost hospital in New Mexico, and we get awards for it, but we definitely don't get money for it. We made a very deliberate choice that we did not charge for testing unless we had to actually pay for it. We charged the insurance companies, and then for immunizations, we didn't even build insurance companies. We found that it was such a hassle and the reimbursement was so bad anyway, that we were able to purchase a lot of collateral within our community by saying, this is not about the money, this is about keeping our community as healthy as possible. So we were able to reach 50% really early of vaccination rates, and right now we're at 70%, and still struggling to get some more hesitant people in, but we'll keep doing it as long as people keep coming in.
Right. Well, I want to thank all of you so much for all of your contributions today. Christina Campos, Tracy Donegan, Peter Wright, for your wisdom, insight, and leadership. You guys rock. Taylor and the ScaleHealth team, thank you for being at the intersection of healthcare and social justice, because quality healthcare is an act of social justice. Also, thank you for allowing me to hold space for you all today. And in the words of the Honorable John Lewis, when you see something that is not right, not fair, not just, find a way to get in the way and to get in trouble, good trouble, necessary trouble. Cheers to all the good trouble with silver linings that I hope you get into. And I will now give the virtual floor over to India Williams, Executive Director of ScaleHealth. Bye now and be safe.